Okay, we are going to be talking about anti-infectives for the next few videos. This one is going to be kind of an introduction to anti-infectives and to microbes in general, and then the next video or two will be talking about the individual anti-infectives. So in the beginning of this portion of your unit, which is Unit 8, for the anti-infectives, there are some definitions that you want to look over. I'll probably be hitting them for the most part throughout this conversation, but those are some words that you might want to be familiar with before you really dive into this. So basically what we know is that the body has adapted to living comfortably with a world full of microorganisms, as many of you know, because I believe at this point almost all of you have probably completed microbiology. They're in the food, they're in the air, they're in the water, they're in the soil, they're all over the place, and they're super important components of life on Earth, as I'm sure you know. It's interesting and fascinating to me that there are actually way more bacterial cells in or on a human body than there are human cells, and some people have gone as far as to say we humans are just elaborate housing for microbes. So this is an area of great interest and lots of research, the human microbiome, and trying to figure out really what the deal is with all these microbes. However, that's not what we're talking about. We're not talking about peaceful coexistence here today. Instead, we're talking about pathogenicity and virulence and the use of anti-infectives for that cause. So essentially, a pathogen is anything that can cause disease because of their ability to invade human tissues or secrete toxins that damage, or that should say kill, or kill human cells. So that's what a pathogen is. And of course, there's all kinds of different pathogens: bacteria, viruses, fungus, unicellular organisms like protozoa, and multicellular organisms like fleas, mites, ticks, etc. So there's all kinds of options for pathogens. When that term pathogenicity is referring more to the speed in which these organisms are reproducing. And more importantly, when they're reproducing quickly, they oftentimes are going to overcome the body's defenses. So that's really what this is about. Opportunistic pathogens are really only a problem when the immune system is actually compromised. So when we're trying to think about pathogenicity, oftentimes the term virulence is used, and virulence is simply a measure, quantitative measure of an organism's pathogenicity. For example, a highly virulent organism can produce disease even when there's only a little bit of that microbe present, right? So the microbe concentration is small, but it's really still able to produce disease in human. So that would be a highly virulent organism. The two main factors that determine virulence are invasiveness and essentially what kind of toxins are being released. So invasiveness, again, sort of just refers to the very quick growth and damage to surrounding tissues as a result of this invasion from these pathogens or a pathogen. And this really is a problem when the immune system is slow to mount an immune response. That's where we're going to really see a lot of issue. I mean, there are some organisms that are so incredibly virulent that even if the immune system is strong, they still are likely to result in some degree of disease. But if the human immune system or the defenses are down, that's when this really becomes a very severe problem. So the other the other issue is what sort of toxins are being produced by these organisms. And there's two that we're going to talk about. The first is exotoxins. Exotoxins are proteins that are released by bacteria into surrounding tissues that can inactivate or kill the host cells. A great example of this is Clostridium botulinum, which is probably one of the most potent, if not the most potent toxin known, that binds essentially to presynaptic motor neurons, which subsequently prevents the release of acetylcholine. So it's an incredibly virulent organism because of this exotoxin. Generally, symptoms of exotoxin-producing bacteria are usually caused by the toxin itself and not the bacteria. A very good example of this would be food poisoning. Most exotoxins that are secreted by bacteria are water-soluble, and they can easily enter the blood and therefore can be transported throughout the body and cause systemic disease. So that's one type of toxin. Another type of toxin is an endotoxin, which is a harmful non-protein chemical that can be part of the outer layer of the normal cell wall of a gram-negative bacteria. And after the bacteria dies, as a in most cases due to either the immune system's attack or in the case of anti-infective administration, after the bacteria dies, the exotoxins are liberated into the surrounding tissues. And essentially what that does is it causes macrophages to release a huge amount of cytokines, which kicks off a big-time inflammatory response. So again, initial doses of bacteria antibiotics can precipitate this reaction. A couple notable microbes that are known to produce endotoxins when they are destroyed are Proteus, which is a big player in urinary tract infections, and also Neisseria meningitis is another organism that releases endotoxins. So this is a big issue. All right. So first, I kind of want to talk, and I'm jumping a little bit around out of order from what you have in your textbook. I want to talk about first classifying the bacteria, and then I want to talk about how to classify anti-infectives in a general sense, and then we'll get into the details of the individual classes in a little bit. So classifying bacteria. So why this is important is because ultimately when we wrap it up, when we try to figure out how to choose the right drug, it's really helpful to know what kind of bacteria you're dealing with, because the treatments are different depending on the different type of bacteria. So essentially bacteria are classified in different ways, which I'm sure most of you guys know by now. They're described by how they stain, by their morphology or their shape, and their ability to utilize oxygen. So the simplest method to identify bacteria, of course, is a gram stain, which I'm sure you guys know, the thick peptidoglycan cell wall, which is unique to the bacteria. When you administer the stain, if the stain is retained, being picked up by the thick cell wall, then we'd say that was a gram-positive bacteria, and you can see some examples of those. Gram-positives are staph and strep and enterococcus. If the walls are thinner, then they tend to lose the stain, and so we call those guys gram-negatives, and these are where the Bacteroidetes gets in, E. coli comes in here, Klebsiella, sorry, that's spelled incorrectly, Pseudomonas, Salmonella. These are examples of gram-negative bacteria. So that's one way we can identify them, is based on how they stain. Another way to identify them is on their shape or their morphology. And so if they're rods, we call them bacilli. If they're round or spherical, we call them cocci. If they're shaped like a spiral, they're called sporilla. So that's another second way to identify a bacteria. And then the other third here is whether or not they use oxygen. An oxygen using bacteria is aerobic. One that doesn't need oxygen would be considered anaerobic. All right, so that's the first way in terms of how to classify bacteria in a very general, simplified manner. All right, so when it comes to classifying antibiotics, we basically want to classify them based on their ability to kill or inhibit replication of the invading organisms without a whole bunch of damage to the host cells. The way they're designed is they're designed to interfere with some phase of the bacterial cell physiology, right? That's unique to that pathogen. That's what makes this different than what we're going to talk about in subsequent videos on anti-neoplastic agents, right? These are foreign cells, so they're different. They're built different. and they have different markers. So and there's features that are unique to each of these bugs. And so the drugs are designed to interfere with a portion of the physiology of that pathogen and leaving the human cells ideally alone. They're oftentimes classified according to their mechanism of action, their chemical structure, and their spectrum of activity against particular organisms. And we're going to kind of get into that a little bit more. The term anti-infective is a super general term that really applies to any medication that's effective against pathogens. So a lot of this is semantics, but an anti-infective could be subdivided into antibacterials, antivirals, antifungals, antiprotozoals, etc. The term antibiotic traditionally refers to a natural substance that's produced by a microorganism that then can kill other microorganisms. For example, penicillin, right? Penicillin is produced by a mold, and the penicillin then was what killed the microbes, right? So that would be a true antibiotic. Newer drugs now we're not really synthesizing from natural substances. Most of them are made synthetically in a lab. And so they would be called antibacterials rather than antibiotics. But in reality, antibacterial and antibiotic are really used interchangeably in clinic. So it's more of an academic discussion. Again, the class is going to refer to the general chemical structure shared by a group of anti-infectives, and we'll kind of get into that. It's also, again, really useful to separate them by their mechanism of action. Probably that's the most sensible way to do it. All right, so here's a summary of our antimicrobials, the different classes based on their mechanism of action. And I am going to kind of just run you through some basics of these individual classes, and then we will dive into this deeper with each of them individually. We'll separate them all out. So the first ones I want to talk about are, because this is the way we're going to do it in our class, are these guys here, and these are the drugs that inhibit the cell wall synthesis. So bacteria, as you know, have rigid cell walls that create a high osmotic pressure inside the cells. The wall of the bacteria is composed primarily of peptidoglycan, which is essentially a repeating network of carbohydrate and protein chains that are only found in bacteria. When the cell wall of a bacteria is disrupted, essentially what that does is it causes the cell to take on water, and then ultimately it will lyse or explode. Some examples of these are the beta-lactam family, and that's where penicillin, cephalosporins, carbapenems come in. Again, if those names are not familiar to you, do not freak out now. They're going to come next, later. And another example of a little bit of an atypical cell wall synthesis inhibitor is vancomycin. Vancomycin doesn't actually disrupt the cell wall directly. Instead, it prevents the formation of the peptide chains that are used in the construction of the cell wall. So it's a little bit of a different mechanism of action. And they're also different. Vancomycin and the beta-lactam family are, they don't share the same chemical structure. So that's why we kind of separate them. The beta-lactam family of drugs, which again are penicillin, cephalosporins, carbapenems, those all share a similar structure, which is called the beta-lactam ring. That's why they get grouped together like that. More to come on those guys. Okay, let's just go this way. Let's do the protein synthesis inhibitors. So here we have these drugs. There's a few of them that are used fairly frequently. Protein synthesis inhibitors are going to target the ability of the bacteria to make protein. So both human cells and bacterial cells, of course, synthesize proteins. We know this. However, the ribosome, which is the organelle responsible for making proteins, as I'm sure you know, the ribosome structure differs in the two types of cells. So the ribosome structure is different in a bacterial cell versus a human cell. And therefore, that allows for the selective nature of these antibiotics in this class that we call the protein synthesis inhibitors. Protein synthesis happens in a multiple step process, which allows for slightly different mechanisms of action of this group of protein synthesis inhibitors. So tetracyclines, aminoglycosides, macrolides, clindamycin, chloramphenicol, they all are protein synthesis inhibitors, but they inhibit the synthesis of protein in a little bit of a different way. For example, the tetracyclines interfere with the transfer of RNA, while the aminoglycosides basically change the shape of the ribosome. And when the ribosome changes shape, protein synthesis is impeded or inhibited. So that's in a nutshell how these drugs work. And again, we're going to talk about them individually. Let's skip, let's see here. Let's talk about these. These are the drugs that inhibit nucleic acid synthesis. So nucleic acid synthesis is important, as we know. Both DNA and RNA synthesis occurs in human cells and bacterial cells, but the structure of the enzymes that is required to do this process is quite different in human cells and bacterial cells. So this is the target of these groups of drugs. By far and away, the fluoroquinolones are the largest group of drugs that inhibit DNA synthesis. Basically, what they do is they affect an enzyme called bacterial DNA gyrase. And basically, what happens is the role, of bacterial DNA gyrase is that it uncoils DNA during the replication process. So similar to how our DNA has to get sort of unzipped so it could be copied, this enzyme does that as well, but it's a different enzyme than we see in human cells. So the target of the fluoroquinolones is that particular enzyme. Let's go, what have I not talked about? These drugs up here, the cell membrane function inhibitors. So bacteria have, again, a cell wall and a cell membrane. So the cell membrane inhibitors are going to interfere with the pathogen's plasma membrane. There's not a whole lot of drugs that fall into this category. Some of the newer drugs, we're going to talk about one at the very end, is going to fall into this category. Amphotericin B, I'll give that as an example, is actually an antifungal medication. And we're not going to talk about fungus, but it's on the list here, so I'll mention it. Excuse me. Amphotericin B shuts down the synthesis of a compound called ergosterol, which is essentially a sterol, right? It's a lipid essential to the integrity of the plasma membrane, just like of the fungal cell membrane. So the membrane of a fungus is a little bit different, and it's made highly of lipids, and so amphotericin B disrupts that. Then finally, our last one over here, I don't think I talked about these ones, and these are drugs that inhibit metabolism. So sometimes we refer to these as anti-metabolites, or what they're doing is they are going to get in the way of the metabolic pathways. So as we know, bacteria divide super fast, and therefore they need a really constant supply of nutrients and metabolites. And so essentially these drugs, the sulfonamides and trimethoprim, what they do is they structurally resemble building blocks that bacteria needs, essentially, in terms of metabolism, metabolic building blocks, if you will. And these drugs, like the sulfonamide, it's structurally similar to some of these building blocks, and therefore it kind of tricks, and I'm saying that in italics, it tricks the bacterial cell into using them for growth. So sulfonamides are notable because if you look up here, they resemble a compound called para-aminobenzoic acid, or PABA. And PABA is a precursor to folic acid. Folic acid is super important. It's essential to the life of the bacteria. And because the drug resembles PABA, but it's not PABA, it can't be converted into folic acid. So it basically, by the nature of taking up the drug rather than the PABA, the the bacterial's protein synthesis is blocked. So it's all super interesting. There's tons of different antimicrobials. We're going to kind of get into some of the details of not all of every single one, because that would be the whole class. Just so you know where this picture came from, this is out of the Lippincott review series, which I actually really like. I probably talked about this in the very beginning of the class. And it's their review series on pharmacology. And I really like some of their visuals, so I'm using them in this presentation. Here's another picture that I found someplace else. I don't actually know where. It's similar. It's the same information. It's just a little picture. I couldn't decide which one I liked more, so I put it on here. This actually incorporates some of the newer drugs, like daptomycin and some of the polypeptides. All right, so let's continue. All right, so again, we kind of get into this, like, how do you choose, how do we start? One of the things we have to do is look at the nature of the drug. And so drugs are kind of divvied up into two big categories. They're divvied up into a lot of categories, but two things that are important are whether or not the drug is considered bacteriostatic or bactericidal. A bacteriostatic drug is a drug that's going to stop microbial growth and replication, severely limiting the spread of infection. But, excuse me, I have the hiccups horribly. But what the important thing about bacteriostatic is that the host's immune system still has to be able to eliminate the pathogens. So it's kind of like a stun gun, if you will, for pathogens, right? It slows them down, but it doesn't kill them directly. The host's immune system really has to still step in and do that. Bactericidal agent, on the other hand, kills bacteria, immediately decreasing the number of viable pathogens in a host. So if somebody's immune system is not up to par, then this is going to be a better way to go, right? If someone's got a compromised immune system, then a bactericidal agent is going to be the choice. Also, if the pathogen is highly virulent or the infection is life-threatening, then a bactericidal agent would be the way to go, because it's going to be a lot faster, right? It doesn't rely on the immune system and all of that. Instead, it just kills the microbe directly. So bacteriostatic and bactericidal are terms you're going to hear when we talk about the individual antimicrobials, whether or not it's one or the other. In some cases, it's both, but in very few cases. Okay, another important thing to think about when we think about selecting a drug is the spectrum. So the antimicrobial spectrum refers to the range of pathogens that can be affected by the drug. That's what the spectrum is all about. So when we think about the spectrum, the terms that are going to be familiar are narrow spectrum, broad spectrum, and extended spectrum. So if you look on the side of your slide here, you'll see another visual from the Lippincott book, which I like a lot. And up here in this first box, this is representing medically important microorganisms. You see gram-positive cocci, gram-positive bacilli, gram-negative cocci, etc. So you don't need to memorize this, but just sort of eyeball it, right? So these are our medically important microorganisms. So then we have a drug like isoniazid, which is a narrow spectrum drug, right? It's one of the ones that we were just talking about, a cell membrane, inhibitor. And it's a drug that we use for tuberculosis, and that's pretty much what it's good for, right? So you see, it only covers one piece of the pie right here. None of these. So that would be a very narrow spectrum drug, meaning it's acting on a single organism or very few organisms. Then we go down to I'm skipping out of order. We go down to our broad spectrum down here, which is tetracycline, is a great example of a broad spectrum antimicrobial. And look, if you just compare this picture to this one up here, this is almost covering the whole pie, right? Just a couple of pieces are cut out of this. So that would be a pretty broad spectrum drug, meaning that it has an intermediate range of activity and targets a whole bunch of organisms, in many cases gram-positives and gram-negatives. The worry about using these broad-spectrum antimicrobials is that they're going to kill, and remember in the very beginning of this I said we have more bacterial cells than we have human cells, and most of them are commensal, right? Most of them are not pathogenic. They're there for a reason, and the more and more we learn, we are seeing that there are actually very good reasons for those bacteria to be there. And by wiping them out, that can be and has shown to be clinically quite a big issue. So choosing a broad spectrum drug, unless you have no other choices, probably is not a great idea. There are reasons to choose them, but as a general practice, should be curtailed. And then we have I'm sorry, I think I said something out of order. I think I was talking about extended spectrum when I was meant to say broad spectrum. So broad spectrum is against a whole bunch of pathogens. The extended spectrum is what I was reading when I was talking about broad spectrum, pardon me. The extended spectrum right up here, this is a drug called ampicillin. So basically with extended spectrums, what we do is usually have an original drug like where we see a lot of extended spectrums is in the beta-lactam family. So let's say with penicillin, right? Penicillin started off as just penicillin G, and then it worked great, but then there was this resistance issue. So then the newer versions of penicillin picked up more efficacy against different microbes. So when we extend the spectrum, we have we cover a broader range of microbes. And so again, in that picture, you see ampicillin, which is an extended spectrum antimicrobial. We've got it being reasonably effective against listeria, which is a gram-positive bacilli, and also against some of our gram-negative rods, Salmonella, Proteus, H. flu, and E. coli, right? So that's an example of an extended spectrum. And as we get into the beta-lactam families, we'll see pretty good examples of extended spectrums. Again, we worry a little bit with the extended spectrums about the flora as well, the commensal flora, if you will. Okay, so what I really want to do in this video is talk to you about mechanisms of resistance. So this is a big deal, right? Antibacterial resistance is reaching, I would say, from my opinion at least, epidemic proportions, and I think has the potential, if not the probability, of creating a major health crisis. So basically, and there's a lot of confusion around antibiotic resistance and what the heck that all means. So essentially, bacterial resistance develops if the growth is not stopped by the maximal level of the antibiotic that is tolerated by the host, right? So what that means essentially is the organisms are then able to mutate and develop more virulent strains. The main mechanisms of resistance, and I'm going to kind of talk about them a little bit independently. One is, so again, this is what we're seeing here essentially in a nutshell is we've got these antibiotics that were effective against, whether they're narrow or broad or whatever, but they were effective against certain organisms. But then over time, we've seen a decrease in effectiveness. So this is oftentimes referred to as acquired resistance. So, for example, like in the mid-1950s, right, that's when penicillin hit the scene and was considered a miracle drug, right? Because it was killing microorganisms that had previously been killing people, right? The ones that weren't that big of a deal, strep, staph, those kinds of things. So it was great. And everybody was using it for everything you could think of. But what we saw was the drug rapidly became ineffective. So essentially, acquired resistance is referring to the ability of the organism to become unresponsive over time to the effects of the antibiotic. And this can occur in all microbes. So the ways by which the bacteria, I'm just going to use the term bacteria, the microbe becomes resistant is what we're talking about here. And this kind of gets crazy. So the first is one mechanism of resistance is the destruction of the drug. So essentially, organisms can produce organisms, meaning the microbe, can produce enzymes that can destroy or deactivate the drug. When we get into our classes, individual classes, we'll see that when we talk about the beta-lactam family of microorganisms, of anti-infectives, with those, they all share a similar structure. And so what we see is and penicillin is one of those, is that the microbes basically started producing an enzyme called beta-lactamase that splits the active portion of the drug molecule, breaks it up, so it's no longer effective. So the bacteria itself is producing an enzyme that deactivates the drug. That's one mechanism of resistance. Another is the prevention of the drug from entering the pathogen, So some microbes have developed enzymes that inactivate the drug as it crosses the cell wall. Others have changed the structure of the channels or the pores that the drug would normally use to enter the cell. This has happened with penicillin, and this previous mechanism also tetracycline. This is a big deal with tetracycline. Okay, so that's mechanism number 2. Then we have the ability to remove the drug by resistance pumps. Some bacteria have developed a system that essentially rapidly pumps the antibiotic out of the bacterial cell before it can reach its intracellular targets. So these are for like the drugs that are protein synthesis inhibitors, right? Before the drug can get in there to bind the ribosome, for example, the drug gets pumped right back out of the bacteria by a resistance pump. The bacteria has evolved to produce. Alteration of the drug's target site is another one. Most drugs bind to a specific receptor that's located on the surface of the cell or inside the bacteria. And if the shape of the receptor is changed or altered, the drug can't bind, right? We know this is like how enzymes bind substrates. This is really common with the sulfonamides. With the macrolides, another group of drug, we have seen mutations occur that result in the changes of the structure, of the ribosome, right? So it's changing the shape of the drug target site. And then finally, the development of alternative metabolic pathways. So some antibiotics act by depleting the pathogen of the necessary nutrients or metabolites. Those are the last ones we talked about. And those nutrients and metabolites are needed for growth and reproduction. And so basically what we see is the resistant organisms have survived the antibiotic application by making larger amounts of the substance or by finding another way to get it, another means of acquisition of that nutrient that it needs in order for it to persist. So it's kind of crazy. Here's a picture of some of these things I was talking about. I should have kind of had it up as we go. So these would be, again, these are drugs that bugs that have become resistant because they alter the target binding site, whether it's an enzyme, whatever it is. These are mechanisms of resistance. These drugs have made it so the drug gets kicked out, it's spit out of the cells, and these have made it harder for them to get into the cells. And these are drugs that have, basically inactivated enzymes. So there's all kinds of ways. You can spend a little time looking at that if you're interested in it. So it's kind of scary. Well, I think it's really scary. But we kind of want to think about, how is it that bacteria can change their physiology to become resistant? What the heck is going on here? And really what it all kind of boils down to is in the nature of bacterial cell division. So if you remember, bacteria divide via a process called binary fission, which is extremely fast. They replicate like crazy. I put an example there just so we can get a feel for this. E. coli can produce 1 million cells every 20 minutes, or 10 to the 21st power cells in 24 hours. That is a lot of cells. And during exponential division, which is how bacteria divide, they make lots of mistakes, right? You learned about this in biology probably, or even in micro, hopefully. Anytime you have a copying error when you're dividing, which is happening really, really fast, errors occur, and those errors are called mutations, right? And I think what's kind of important is to understand, at least for me, it was important to understand, was that this is just totally by chance, right? These mutations are spontaneous and they're random. There's not like an end game by bacteria to like eradicate the human race. That's not what's happening, right? Evolution doesn't have a goal, right? It doesn't have a future goal. It's just happening. It's due to changes in the now, changes in the environment. And so these mutations are totally spontaneous, they're random, and occasionally, sometimes they're detrimental to the bacteria, but occasionally physiology is altered in such a way that it gives the bacteria a reproductive advantage, right, over the neighboring bacteria. And once that happens, the bacteria with the reproductive advantage then is going to continue to divide and divide and divide, because that's what bacteria does. And it's going to pass that mutation on every time it divides, like we do when we copy genetic information. So once the mutation has resulted in a resistant strain, meaning the microbe is resistant to the medication, it's gained something that makes the medication ineffective, essentially, then the microbes are going to permanently lose sensitivity to that specific drug. And unfortunately, oftentimes to the other drugs that are in the same class, meaning that they share a similar mechanism of action. So that is, this is evolution, right? This is what happens. But it's just happening in a way that's really fast because of the nature of bacterial cell division. So what do we do about this? How do we prevent this from happening? Well, one thing that we know is that the widespread use of antibiotics has promoted the development of drug-resistant bacteria. That we know. And by killing strains of bacteria that are sensitive to the drug, when you administer the antimicrobial, the only bacteria that will remain in order to replicate are those that have acquired the mutations that confer resistance. So after that resistance, of course, is conferred, remember that mutated bacterium can pass its resistance to other bacteria via either binary fission or through conjugation, if you remember about that. And that ability to directly transfer the plasmid, the circular DNA, right, from one bacteria to the other means that bacteria that have never actually been exposed to the antibiotic can then become resistant. So what are we going to do about this? How do we prevent this from happening? This Centers for Disease Control has put up some guidelines to minimize antimicrobial resistance. And I think for the most part, this is pretty obvious, but in healthcare, we have to kind of be very vigilant about this. One is to prevent infections whenever possible, meaning don't minimize the use of antimicrobials. Do everything you can to keep infections from taking hold. If somebody does have an infection, diagnose it and treat it properly, meaning identify the bug and choose the most appropriate drug with the most narrow spectrum to do the job. Only prescribe antibiotics when there's clear rational reason for it. And that kind of sounds counterintuitive maybe, but it has been pretty common in practice to give an antibiotic for, like, say it's something like a respiratory tract infection, which are 90% or greater of them are viral. But people come in and they're given an antibiotic. people in the trenches know that viral respiratory infections are viral, but the feedback from the clinicians is that the people are there, they want an antibiotic, they want to feel better, so you just give them an antibiotic, and sometimes they do feel better. And what we're learning, I think, about antibiotics, which is interesting, is in addition to the antimicrobial effect, many of them have anti-inflammatory effects as well. And I think that the reason why they feel better, because I've always wondered about that, like, well, if you give them an antibiotic and they feel better, did they have a bacterial infection? Not necessarily. If it has an anti-inflammatory component, that's probably what's making them feel better. If somebody does need to take an antibacterial and there's clear and rational reason to prescribe it, then you want to make sure they take it for the full length of therapy to try your best to eradicate those bugs and not leave a few of them around so they can, potentially mutate. And the other one I think that is really important is to prevent the transmission of infections. And this is super important for us healthcare providers because healthcare associated infections are common and they oftentimes are resistant to common antibiotics. So, this is things like sterile technique, hand washing, cleaning everything up, etc. All right. I want to finish with just a couple more things. One thing I want to mention is a couple problematic strains where we see a lot of resistance, and one is methicillin-resistant Staph aureus, or MRSA. Methicillin was a drug that was used to treat staph at one point, but it's completely ineffective, and so it doesn't ever really get used, but it's retained the name and given the headline, if you will, of the MRSA. So MRSA strains are resistant to methicillin, amoxicillin, and penicillin. There's hospital-acquired, that's what that HA stands for, or community-acquired MRSA. The hospital-acquired MRSA tends to be more resistant than the community-acquired MRSA. Community-based infections usually are manifested in the skin or soft tissue. That's generally where we see community-acquired MRSA infections. MRSA strains have actually developed resistance to even more antimicrobials, including the fluoroquinolones, the macrolides, the immunoglycosides, tetracycline, and clindamycin. So for a while, the only drug that worked was vancomycin, which is a cell wall synthesis inhibitor. But what we've seen in recent years is there's resistance appearing also to vancomycin. There's a couple newer drugs, which I put on the slide there, linezolid. I have a hard time saying that one. And I'm not even going to try my best to pronounce quinupristin and dalfopristin. Quinupristin and dalfopristin are drugs that essentially are going to be protein synthesis inhibitors. They're kind of two drugs combined. They're sort of interesting because on their own, they're bacteriostatic, but in combo, they have a bactericidal effect. So that's really helpful because especially with these hospital-acquired MRSA infections, they can get really bad really quick. And daptomycin is a drug that disrupts the cell wall. Remember, there weren't very many of those. This is a newer drug. It's a cell membrane disruptor. Another problematic strain is a bug called vancomycin-resistant enterococci, or VRE. Enterococci are pretty regular inhabitants of the gut and also the female genital tract, but they're also found frequently in wounds and pressure ulcers in people in the hospital. The people who are really at risk for VRE are the people that are immunocompromised. These enterococci are super hardy organisms, and they can hang around for a pretty long time on environmental surfaces. So the healthcare workers really need to be aware of this. This is where very good prevention techniques come in. Because they can be spread like wildfire through the hospital setting. 100% of the VRE strains are resistant to ampicillin, which is the drug that has been used traditionally for enterococci. All right. I want to introduce something called a superinfection. A superinfection is essentially a result of the administration of an antibiotic that kills a whole bunch of the flora of the host, in addition to probably some of the flora, the pathogens. So what it's doing is it's kind of wiping out the commensals, if you will. So what we know about the presence of all these microbes, that we have more microbial cells than human cells, it's not just a coincidence that we are more bacterial than we are human, right? They do a lot of stuff for us, or depending on your perspective, we could say we do a lot of stuff for them, or we're doing a lot for each other, maybe. But one thing, the presence of the microbes, the commensals, is they antagonize the growth of pathogens. And so when we wipe out the commensals, we don't, and especially if you have a resistant strain, then we're really kind of up the creek without a paddle, because we've got these mutated pathogens going crazy. But even if there's not a resistance happening, we just have this kind of leveling of the field, and if we don't get all the pathogens, then we can get a secondary infection. So a superinfection is a completely new infection. Right? It's not related to the original infection. It's related to the antibiotic use. The most common superinfections are seen or manifest in terms of symptoms in diarrhea, bladder pain, urinary tract issues, painful urination. That word is just misspelled. I guess I didn't run spell check. And also abnormal vaginal discharge. The superinfections are a lot more common with our broad spectrum antimicrobials because they kill so much stuff, as we talked about earlier. All right, so last thing here, where do you start? How do we know what to do with these when we are trying to select an antimicrobial? So it really kind of boils down to three main things. The first thing is identify the organism. You got to do that, right? And that can be done and should be done via laboratory examination, but it doesn't. What we should do and what we do aren't always the same thing. So oftentimes we go by what we call empiric therapy or best guess approach, meaning that you know what kind of an infection you are and you know the microbes that most commonly cause those infections, which I'm going to show you in the next slide. So you give a drug based on your best guess, and for the microbe that you think is the problem. And then if that doesn't work, then you would follow it up with, a more targeted approach. And ideally, in this case, that you've taken some culture, you've grown out the bug, and you now know what you actually have there. So doing some testing, and there's a bunch of different types of testing, which you guys learn in micro, I'm sure, Kirby-Bauer, the minimum inhibitory concentration, minimum bacterial concentration, all of these things. These are different different methodologies to try to really figure out what's the best drug for the bug. And then you kind of take into consideration the drug itself, the spectrum. You want to kind of think about the pharmacokinetics of the drug. You want to make sure it's going to, and this is kind of an important thing depending on the infection, you want to make sure it's going to get there, right? That's a big deal. And there's some that are super hard to get to, like infections in the brain or in joints or something along those lines. And then, of course, how easy it is to give. Can you give it oral? Do you have to do it IV? And then safety considerations always should be considered, as we know. And then we have to think about the patient. It's the patient that's, on the line here. What other sorts of things do they have going on that might limit the effectiveness or the safety of the drug? What other medications are being used? Are there any interactions? Those kinds of things. Are they going to be able to do it? Can you trust them to take it? That's a big problem. It seems like not a big deal, but compliance is a huge issue with antibiotic treatment. People tend to, especially if you choose the right drug, they tend to feel better very quickly. And so oftentimes they will stop taking the medication, which we already talked about. That's one of the things that promotes resistance. So we want to make sure that they really know how to do it, and they're going to be able to do it, and they're going to be able to comply with the recommendations. So for your own personal use, I found this slide somewhere. I don't know where, but I kind of like it because it gives you, and you can print this and have it and put it somewhere. It gives you some of the more common bugs for different conditions. For example, If we look over here at the ENT section, we think of like your standard otitis media, right? And these are the organisms that oftentimes are implicated. Sinusitis, right? These are the organisms that are oftentimes indicated. Otitis externa, endocarditis. Then we've got our GI microbes down here. Gastroenteritis, genitourinary, right? These are big reasons for antibiotics. UTIs. These are oftentimes the organisms. Foot infections with diabetics, respiratory infections. Just to clarify, in case you don't know these terms, CAP is community-acquired pneumonia. HCAP would be healthcare-associated pneumonia. VAP is ventilator-acquired pneumonia, and this would be HAP would be just hospital-acquired pneumonia, which is kind of the same as healthcare. So that's this sort of helps to be like, okay, now I have a pretty good idea of what the bug potentially is. And then you would try to find the drug that's most appropriate for that bug. Here's another kind of way to break it down. It's a little bit easier in terms of the type of bacteria. And, where you probably are finding these guys, like the gram-positive cocci, skin, soft tissue, lung, bone, joints, right? Hardware, meaning they have had something in placed like pins or screws, indwelling lines. So these are just for you. You don't memorize it. That's not the point, but just for you to have for some information. All right, so we're going to come back and we're going to talk about these different classes of drugs independently. I'll see you in a little bit.